Welcome back to the Deep Dive. Our mission, as always, is to get past the surface level, dig into the complex details, and really equip you with that mastery-level understanding you're looking for.
Exactly.
And today, we are doing just that with a really comprehensive technical look at pregnancy diagnosis. We're talking about the signs, the tests, the measurements, basically the whole architecture of how it's done in modern obstetrics.
That's right. We're definitely moving beyond the basics here. The goal is for you to walk away understanding the entire sequence, from the very first hint a woman might feel, all the way to that definitive ultrasound picture.
And not just what the signs are, but really why they matter, clinically, quantitatively.
Precisely. It's about understanding the significance behind each piece of data.
Okay, so let's set the stage first. The basic parameters of human reproduction. What's the typical window we're talking about?
Well, the standard definition covers the period from menarche, so the first period right through to menopause. Generally, that maps onto about 13 years old up to around 45.
That's the general range, but biology isn't always standard, is it? There are variations, extremes even.
Absolutely, and it's crucial to remember that. The sources we're drawing on highlight that pregnancy is extremely rare below 12 years and also very rare beyond 50.
Those outliers, they really underscore why we need objective data, don't they? Can't just rely on age.
Exactly. Assumptions based on age alone just aren't enough. You hear about the record cases.
Right, like Lena Medina in Peru, giving birth at just 5 years and 7 months. It's almost unbelievable.
That is stunning. And then on the other end, the oldest recorded case at 57 years and 4 months.
So these extremes, they hammer home the point that you need objective tests. The biochemistry, the physical signs we're going to discuss, they're non-negotiable, regardless of age or history.
Precisely. Clinical judgment must be backed by solid evidence.
Okay, before we even get to symptoms, there's a fundamental definition we need to nail down. There are 2 ways pregnancy duration is calculated, and mixing them up causes real problems. Let's clarify gestational age versus fertilization age.
Yes, this is absolutely fundamental. Clinicians typically use what's called menstrual or gestational age.
Okay.
This is the one calculated from the first day of the woman's last menstrual period, the LMP.
Right, LMP. We hear that acronym a lot.
We do. And this method gives you that familiar 40-week count or 280 days. Sometimes it's phrased as 10 lunar months or 9 calendar months plus 7 days. It's a convenient starting point for clinics.
But biologically, it's not quite accurate, is it? The baby isn't actually 40 weeks old at birth in terms of development time.
Correct. Fertilization doesn't happen on day 1 of the cycle. On average, in a typical 28-day cycle, fertilization occurs about 14 days after the LMP.
Okay. So that's where the other calculation comes in.
Exactly. That's the fertilization or ovulatory age, sometimes called true gestation. This reflects the actual age of the embryo or fetus.
So how do we calculate that?
Simple subtraction. You take the 280 days of the gestational age and subtract those 14 days. That leaves you with 266 days.
That 14-day difference, that sounds like it could be really significant clinically.
It's critical. It impacts everything from interpreting early ultrasounds to timing interventions later on. We absolutely have to keep that 2-week gap in mind.
Got it. Gestational age clinician's tool, fertilization age, the biological reality. So let's dive into the first trimester, the first 12 weeks. This is where diagnosis often starts with presumptive symptoms and probable signs.
Right. Starting with subjective symptoms, these are the things the woman herself experiences. And the classic one, the primary suspect, is amenorrhea.
Meaning the absence of her regular period.
Correct. If you have a patient of reproductive age, someone with previously regular cycles, and she presents with a missed period, pregnancy immediately jumps to the top of the list of possibilities.
But it's not always that clear-cut, is it? There's an exception that can cause confusion, something called the placental sign.
Yes, this is a really important distinction to make. Our sources confirm you can actually have some scanty, short-lived cyclic bleeding occurring up to about 12 weeks of gestation.
Okay, so like a light period.
Sort of, but it's physiological, not pathological. It happens because the uterine lining, the decidua, hasn't completely fused yet. There's still a potential space, the decidual space between the decidua vera and the decidua capsularis.
Ah, I see. So until that fusion happens.
Until that fusion obliterates the space, usually around 12 weeks, a small amount of bleeding can occur, often around the time her period would have been expected.
And the danger is mistaking that for something serious, like a threatened miscarriage.
Precisely. A threatened abortion typically involves heavier bleeding. It might be persistent, often with pain. This placental sign bleeding is characteristically scanty and brief. Careful history taking is key here, alongside other signs.
Okay. Beyond the missed period, what's next? The most famous one, I suppose, is morning sickness.
Ah, yes, nausea and sometimes vomiting. It's highly variable, though. About 70% of women experience it to some degree.
Is it worse in first pregnancies?
Often, yes, in prima gravidate. It tends to peak early in the first trimester. Thankfully, it rarely goes beyond the 16th week, and usually it doesn't significantly impact the mother's health or nutrition.
Unless it becomes severe, like hyperemesis gravidarum.
Right, but that's a distinct clinical condition requiring specific management. Standard morning sickness is usually manageable.
Okay, let's talk about another early symptom. Frequency of micturition, having to urinate more often. This seems particularly noticeable between weeks 8 and 12.
Yes, it can be quite troublesome during that window, and there are actually 3 distinct reasons why it happens then.
3. Okay, what are they?
First, there's a mechanical pressure component. The uterus, while still relatively small, is bulky. Hormonal changes cause it to be exaggeratedly anteverted, tilted forward, so it rests right on the fundus, the top part of the bladder.
Makes sense. Direct pressure. What else?
Second, there's a local effect. You get generalized congestion of the bladder lining, the mucosa, just due to all the increased blood flow in the pelvis during early pregnancy.
Okay, so pressure and local irritation. What's the third?
The third is systemic. There's a change in maternal osmoregulation, how the body handles fluids. Pregnancy hormones shift the thirst threshold and fluid balance, often leading to increased thirst and, as a result, polyuria, meaning increased urine production.
Wow, so it's a triple whammy on the bladder. Pressure, congestion, and making more urine. No wonder it's noticeable.
All converging in that 8 to 12 week period.
Why does it tend to ease up after the 12th week?
Because the uterus continues to grow, and as it does, it lifts up out of the true pelvis and starts to straighten up a bit. This takes that direct mechanical pressure off the bladder fundus.
Ah, okay. But it can come back later, right?
It often does, yes.
Yeah.
Near the end of pregnancy, when the baby's head engages deep in the pelvis, it puts pressure on the bladder again, and that frequency can return.
Got it. And what about other early feelings? Breast changes, tiredness?
Yes, rounding out the subjective symptoms, women often report breast discomfort, a feeling of fullness, maybe a pricking or tingling sensation. This is often noticeable between the 6th and 8th weeks, especially in a first pregnancy. And general fatigue is very common early on, too.
Okay, so those are things the woman feels. Now let's shift to the objective signs, things the examiner can actually detect. This moves us towards a probable diagnosis.
Right. These signs are particularly valuable if the LMP is uncertain or if the woman presents very early. Let's start with the breasts again, the physical changes an examiner can see or feel starting around 6 to 8 weeks.
What are we looking for?
Clear enlargement is common. And vascular engorgement, the veins become much more visible just under the skin, creating a delicate pattern.
Like a roadmap of veins.
Kind of, yeah. Hormones also cause increased pigmentation of the nipple and the primary areola, the darker area around the nipple. This is usually more obvious in women with darker complexions.
And those little bumps on the areola.
Montgomery's tubercles, they become much more prominent. They're actually modified sebaceous glands. And by about the 12th week, it's often possible for the clinician to express a small amount of thick, yellowish fluid that's colostrum.
Okay. Moving from the breasts down to the pelvis, the increased blood flow there causes some really specific signs, right? Signs of vascular congestion.
Absolutely. The first one is very visual, Jacquemies or Chadwick's sign. You typically see this around the 8th week.
And what is that exactly?
It's a dusky hue, a sort of bluish or purplish discoloration of the vestibule, the area around the vaginal opening and the anterior vaginal wall. It's a direct result of that intense local vascular congestion, just loads more blood in the tissues.
Now, this isn't only caused by pregnancy, is it?
That's a good point. No, other conditions can cause pelvic congestion. So seeing that dusky hue by itself isn't proof positive. But when you see it alongside the other signs we're discussing, the likelihood of pregnancy goes way up.
What else do we see vaginally?
You also typically notice a softening of the vaginal walls. And around the 6th week, many women develop a copious but non-irritating mucoid discharge. Plus, there's a sign you can actually feel.
You mean the pulsation, Osiander's sign.
Exactly, Osiander's sign. It confirms that the vascular changes are palpable. Around the 8th week, during a bimanual exam, the examiner can actually feel an increased pulsation through the lateral fornices, the spaces beside the
So
cervix.
the blood flow is so increased you can feel the pulse in those vessels.
Yes, the dilated uterine artery branches are right there. It's quite distinct and offers immediate objective evidence of significant pelvic engorgement.
Okay, let's talk about the cervix itself. There's a classic description of how it changes in early pregnancy.
Right, that's Goodell's sign. It's evident quite early, sometimes as early as the 6th week. Due to increased vascularity, edema, swelling, and hypertrophy of the cervical glands, the cervix softens quite dramatically.
What's the classic analogy for the feel?
The non-pregnant cervix is typically described as feeling firm, like the tip of your nose. But the pregnant cervix, due to Goodell's sign, feels soft and compressible, more like the consistency of your lips.
Like the lips of the mouth. That's quite a distinct change.
It is. It's a very reliable, probable sign.
But hold on. If the cervix gets that soft so early, how does it stay closed and support the weight of the growing pregnancy later on? Doesn't that seem contradictory?
That's a really critical question. The softening of Goodell's sign mainly affects the feel of the tissue, the consistency, due to those vascular and hormonal effects on the ground substance. But the structural integrity, the competence of the cervix to stay closed, relies heavily on the dense collagen fibers, particularly in the upper part and the internal os.
Ah, so it's soft to touch but still structurally strong.
Exactly. If that structural competence fails, that's when you get cervical incompetence, which can lead to miscarriage or preterm birth. So soft feel, yes, but internally it's designed to hold firm until labor.
Okay, that makes sense.
Hmm.
Now let's move to the uterus itself. The uterine sign's size, shape, consistency changes in those first 12 weeks.
Right. The non-pregnant uterus has a pyriform, or pear shape. By 12 weeks, it becomes much more globular, more rounded.
And the size increases rapidly.
Very rapidly. At 6 weeks, it's about the size of a hen's egg. By 8 weeks, think of a cricket ball. And by 12 weeks, it's roughly the size of a fetal head. At this point, it's usually just starting to rise up out of the pelvis and become palpable abdominally.
What about Piskachek's sign? That relates to the shape too, right?
Yes, Piskachek's sign is about asymmetry. If the embryo implants on one side of the uterus, that side might grow a bit faster initially, making the uterus feel irregular or asymmetrical on palpation. One side might feel firmer or bulge more.
Is that permanent?
No, it's usually temporary. As the pregnancy progresses and the whole uterine wall grows and stretches, that asymmetry typically resolves and the uterus becomes symmetrical again. But finding it early on can be a clue.
Okay. And then there's one of the most classic, almost textbook signs, but one that requires skill. Hegar's sign, usually between 6 and 10 weeks.
Yes, Hegar's sign. It's considered a highly probable sign, but as the sources emphasize, it requires a very gentle bimanual examination. You need experienced hands because there's a theoretical risk, however small, of stimulating contractions or disturbing the implantation.
So what exactly is Hegar's sign? What are you feeling for?
It relies on feeling 3 things simultaneously during the bimanual exam. First, the upper part of the uterine body, the fundus, is enlarged and feels somewhat globular due to the pregnancy growing inside it.
Okay. Enlarged upper part.
Second, and this is the crucial part, the lower uterine segment, the bit between the main body and the cervix called the isthmus, feels incredibly soft, thin, and almost empty. Extremely compressible.
Right. And the third part.
The third part is the cervix itself, which, although maybe slightly softened by Goodell's sign, still feels comparatively firm compared to that super soft isthmus above it.
So when you do the bimanual exam with fingers in the vagina pushing up and the other hand on the abdomen pushing down.
Exactly. Because that isthmus is so soft and compressible, the internal and external fingers feel like they can almost meet or oppose in that space just below the main body of the uterus.
Giving the sensation that the firm fundus and the firm cervix are almost separate structures.
That's the classic description. It feels like they're barely connected because that middle segment is so soft. It's quite a unique sensation when present. It's found in maybe 2/3 of cases in that 6 to 10 week window.
And one more uterine sign from this early period, Palmer's sign. This one is about contractions.
Yes, Palmer's sign relates to the early Braxton Hicks contractions, which actually start very early, though they're usually imperceptible to the woman then. This sign can sometimes be elicited between 4 and 8 weeks.
How do you do that?
The examiner gently cups the uterus between the abdominal and vaginal examining fingers and just holds it steadily for maybe 2 or 3 minutes.
And what happens?
You might feel the uterus undergo these regular rhythmic contractions. During a contraction, which might last about 30 seconds, the uterus feels firm and well-defined. Then it relaxes, and during the relaxation phase, it feels soft and much harder to delineate.
Is this useful throughout the first trimester?
Not really. It actually becomes much harder to elicit reliably after about the 10th week. As the uterus gets bigger, the overall volume increases, and the relaxation phase between contractions tends to get longer, making those brief firming episodes much harder to pick up manually, so it's more of an early, subtle sign.
Okay, we've covered what the patient feels and what the examiner can potentially find on physical exam, the presumptive and probable signs. But now we need certainty. Let's move into section 2, the science of confirmation immunological tests. This is where biochemistry gives us definitive answers.
Right. This is modern diagnosis. The core principle here is detecting a specific hormone produced by the early pregnancy. Human chorionic gonadotropin, or HCG.
HCG. Got it.
These tests use antibodies, either polyclonal or monoclonal, that are designed to specifically bind to HCG if it's present in the mother's urine or blood serum.
Let's start with the common ones, the ones without radioisotopes, like the rapid tests you can buy. The first type mentioned is the agglutination inhibition test, or LAI. This one works in a slightly backward way, right?
It does seem a bit counterintuitive at first. Think of it like this. You take the patient's urine and mix it with a reagent that contains antibodies against HCG.
Okay.
Now, if the woman is pregnant, the HCG in her urine will bind to or capture all those antibodies in the reagent. If she's not pregnant, there's no HCG in her urine, so the antibodies in the reagent remain free and unbound.
Still with you. What's the next step?
The next step is to add latex particles that have been coated with HCG.
Oh, okay.
Now remember, if the woman was not pregnant, the anti-HCG antibodies are still free. So these free antibodies will now grab onto the HCG-coated latex particles, linking them together and causing visible clumping or agglutination.
So clumping means the antibodies were free, which means there was no HCG in the urine initially.
Exactly. Therefore, for these LAI tests, the key takeaway is agglutination negative pregnancy test. No agglutination means the antibodies were captured by the woman's own HCG, so she is pregnant.
Got it. Agglutination means negative. How sensitive are these?
Their sensitivity is typically around 0.5 to 1 international unit per milliliter, IUML. They usually become positive about 2 days after the missed period.
Okay, so that relies on not seeing clumping for a positive result.
Yeah.
What about the direct agglutination test, or HCG direct test?
This one is more straightforward visually. Here, the latex particles themselves are coated directly with anti-HCG monoclonal antibodies.
Okay.
You mix these antibody-coated particles with the urine. If HCG is present in the urine, it acts like a bridge, linking the coated particles together.
Causing clumping directly.
Right. So in this system, agglutination positive pregnancy test, it's visually direct. These tend to be a bit more sensitive, around 0.2 IUML, and might turn positive 2 or 3 days after the missed period.
Makes sense. Now, for higher sensitivity and specificity, especially in clinical settings or better home tests, we often see enzyme-linked immunosorbent assay, or ELISA tests.
Yes, ELISA is much more sophisticated. It typically uses a sandwich technique. One antibody captures the HCG from the sample, specifically targeting the beta subunit. We call it beta HCG, or beta HCG for specificity.
Okay, beta HCG.
Then a second antibody, which is linked to an enzyme like alkaline phosphatase, binds to a different part of the captured HCG molecule, forming a sandwich.
And the enzyme is the key to detection.
Exactly. You add a substrate chemical. If the enzyme-linked antibody is present, meaning HCG was sandwiched, the enzyme reacts with the substrate, causing a color change. More color means more HCG.
And these are very sensitive.
Extremely sensitive and specific. ELISA can detect beta HCG in serum down to levels of 1 to 2 milli-international units per milliliter, MIUML.
Milliunits, so much lower levels.
Much lower. This means ELISA tests can often be positive as early as 5 days before the first expected missed period.
Wow. 5 days before. That really changes the timeline for knowing.
It's a fundamental shift in early pregnancy management, absolutely. Being able to confirm things that early is huge.
Okay, so those are the more common types. Now let's talk about the really high sensitivity assays, the elite tools, often using radioisotopes. These give you numbers, not just yes, no.
Right. These are crucial when you need quantitative measurement, not just qualitative, especially if you're monitoring a potential problem. The most sensitive is the radioimmunoassay, or RIA.
RIA.
RIA uses antibodies labeled with a radioisotope, typically iodine-125 iodo-HCG. It can detect beta-HCG in serum down to incredibly low levels, as low as 8.002 IU/mL.
0.002. That's practically detecting implantation itself.
Pretty much. RIA can confirm pregnancy as early as 8 to 9 days after ovulation, which is right around the time the blastocyst implants into the uterine wall.
Amazing. What's the downside?
It takes time, usually 3 to 4 hours, to run the assay, but its power is in the quantitative result. We use serial RIA measurements to determine the HCG doubling time.
Why is doubling time important?
In a normal early intrauterine pregnancy, HCG levels roughly double every 48 hours. If the doubling time is significantly slower, it's a strong indicator of a potential problem, like an ectopic pregnancy or a non-viable pregnancy. So RIA is invaluable for monitoring those situations.
Okay, so RIA is super sensitive but takes a while. Is there a faster radioisotope method?
Yes, that led to the immunoradiometric assay, or IRMA.
IRNA.
IRMA also uses the sandwich principle, like ELISA, but uses iodine-125 labeled antibodies. It's much faster results in about 30 minutes, and it's still very sensitive, detecting HCG down to about 0.005 MIU/ml. Speed and sensitivity make it great for rapid quantitative checks, maybe in an emergency department setting.
Got it. And there's one more high-tech one, fluoroimmunoassay, or FIA.
Right, FIA is another highly precise sandwich assay. But instead of a radioisotope or an enzyme, it uses a fluorescent tag on the detection antibody.
So you measure fluorescence.
Exactly. The amount of fluorescence emitted is directly proportional to the amount of HCG present. It can detect HCG down to about 1 MIU/mL. FIA is often used for accurately tracking HCG concentrations over time, for example, after treatment for a hydatidiform mole, where you need precise follow-up.
So with these super sensitive tests, what's the absolute earliest diagnosis is possible?
Using RIA or highly sensitive ELISA, you can potentially get a positive result 8 to 11 days after conception. That's about 3 to 4 days before the expected period.
Incredible. Is there a point where these tests become less reliable?
Yes, interestingly, after about 12 weeks of gestation, by then the placenta is fully established and takes over progesterone production, and HCG levels naturally start to plateau and then decline somewhat. The tests still work, but their main diagnostic utility for simply confirming pregnancy is highest in the early weeks.
We mentioned using them for monitoring ectopics, IVF. What about molar pregnancies?
Absolutely crucial there. For gestational trophoblastic disease like hydatidiform mole or the malignant form, choriocarcinoma serial quantitative HCG testing is the cornerstone of monitoring treatment success. You need to track the levels all the way down to 0 and ensure they stay there.
Okay, let's talk about potential pitfalls. Sources of error, and especially false positives, where the test says positive, but there's no pregnancy.
This is critical for clinicians to understand, especially when results don't match the clinical picture. There are 4 specific situations that can cause a false positive without pregnancy.
Okay, what's the first?
Exogenous HCG injection. Sometimes HCG is given as part of fertility treatments, like a trigger shot to induce ovulation. That injected hormone will circulate and show up on a test for several days afterwards.
Right. Need to know the medication history. What's second?
Delayed clearance of HCG due to kidney problems like renal failure. The body normally produces tiny amounts of HCG even outside of pregnancy. If the kidneys aren't working well, they can't clear it effectively, and levels might rise enough to trigger a sensitive test.
Okay. The next 2 sound more complex.
They can be. Third is physiological pituitary HCG. The pituitary gland in the brain can produce small amounts of HCG, especially around menopause. Sometimes, in very sensitive assays or in certain patient groups, this pituitary HCG can be detected.
And the fourth, most concerning one.
Fourth is HCG production by neoplasms, by cancers, certain non-trochoblastic tumors, cancers of the ovary, lung, bladder, even the GI tract can sometimes secrete HCG. In these cases, the positive pregnancy test is actually acting as a tumor marker.
That completely changes the clinical pathway from obstetrics to oncology.
Instantly. It's rare, but vital to consider if the picture doesn't fit.
Are there other technical issues that can cause errors?
Yes. Occasionally, heterophile antibodies in the patient's own blood can interfere with the test chemistry itself, sort of cross-linking the assay antibodies and giving a false signal. High levels of other substances like hemoglobin or albumin or even luteinizing hormone, LH, which is structurally similar to HCG, can sometimes cause interference or cross-reactivity in less specific assays.
So context and sometimes repeat testing with different methods is key.
Absolutely. Always interpret test results in the full clinical context.
Okay, we've confirmed the pregnancy biochemically. Now let's move through the rest of gestation.
Mhm.
Section 3. The second and third trimesters, weeks 13 through 40. Here, the signs become absolute signs.
Right. Entering the second trimester, roughly weeks 13 to 28, often brings some relief. Those early symptoms, the nausea, vomiting, urinary frequency, they typically subside. Amenorrhea obviously continues.
And the defining new symptom of this phase is quickening, right?
Yes, quickening. That's the term for the mother's first perception of fetal movement. It's often described initially as a very faint flutter, or like gas bubbles.
When does that usually happen?
For first-time mothers, prima gravidae, it's typically felt around the 18th week. But for multiparae, women who've been pregnant before, they often recognize the sensation earlier, maybe around the 16th week. They know what they're feeling for.
Was quickening used historically for dating the pregnancy?
It was, yes. Before ultrasound, it was a key milestone. The rough calculation was to add 22 weeks to the date of quickening for a first baby, or 24 weeks for subsequent babies, to estimate the expected date of delivery, EDD.
Still useful if dates are really uncertain, perhaps?
Potentially as a rough guide, but ultrasound dating is far more accurate now. Still, understanding the concept is important.
What about external signs, things we can see changing on the mother's body in the second trimester?
Pigmentation changes often become more pronounced. Chloasma, sometimes called the mask of pregnancy, which is pigmentation on the forehead and cheeks, might appear around the 24th week.
Okay.
On the breasts, secondary areola can develop around the 20th week. This is a sort of lighter, mottled pigmentation that appears outside the darker primary areola. Montgomery's tubercles remain prominent.
And on the abdomen?
The linea nigra, that dark line running from the pubic bone up towards the sternum, usually becomes visible by the 20th week. Stretch marks, or striae, may also start to appear on the abdomen, breasts, or thighs.
Fundal height, measuring the top of the uterus, becomes a really practical tool now, doesn't it, for tracking growth?
Absolutely. It's the clinical rule of thumb for estimating gestational age in the mid-trimester. Knowing the landmarks is key.
Okay, walk us through those landmarks.
At the 16th week, the top of the fundus is usually palpable about midway between the symphysis pubis, the pubic bone, and the umbilicus, the belly button.
Halfway point at 16 weeks.
Okay. By the 24th week, it typically reaches the level of the umbilicus.
At the belly button at 24 weeks.
And by the 28th week, it's risen further, usually to the junction of the lower third and upper two-thirds of the distance between the umbilicus and the xiphoid process, or ensiform cartilage, the bottom tip of the breastbone.
Got it. 16, 24, 28 weeks. Key points for fundal height. Now we're getting into the absolute positive signs of pregnancy, things that are undeniable proof.
Yes, these are the clinical certainties. First, the examiner being able to distinctly feel, or palpate, fetal parts like a head, back, or limbs. Second, the examiner directly feeling active fetal movements.
When can the examiner usually feel those?
Both are typically possible by the 20th week. Feeling those definite movements through the abdominal wall is absolute proof not just of pregnancy, but of a live fetus.
There's also external ballottement. What's that?
Ballottement is a French word, basically meaning tossing. External ballottement can often be elicited around the 20th week, especially when the fetus is still relatively small compared to the amount of amniotic fluid.
How does it work?
You give a quick, gentle tap or flick to the fetus through the abdominal wall. Because it's floating in fluid, the fetus will move away and then gently rebound back against your examining fingers.
Like tapping an ice cube in a glass of water.
Exactly that principle. It confirms there's a movable object within a fluid-filled cavity. It gets harder to do if the woman is obese or if there isn't much amniotic fluid, what we call scanty liquor.
But the most conclusive clinical sign of all, the one that silences almost all doubt.
That has to be hearing the fetal heart sounds, the FHS.
When can you typically hear that?
With a standard Pinard stethoscope, or a regular stethoscope, you can usually pick up the fetal heart sounds between 18 and 20 weeks. The rate is key. It's much faster than the mother's, typically ranging from 110 to 160 beats per minute.
And technology lets us hear it much earlier.
Yes. Using a handheld Doppler ultrasound device, which detects the motion of the heart valves or blood flow, we can reliably detect the fetal heart rate much earlier, usually by the 10th week, sometimes even a bit sooner.
Now, when listening, it's crucial to distinguish the baby's heartbeat from other sounds, isn't it?
Absolutely critical. There are two main sounds you might hear that can be confused with the FHS. First is the uterine souffle.
Souffle, like a soft blowing sound.
Exactly. It's a soft, blowing systolic murmur, meaning it occurs in time with the mother's heartbeat, synchronous with the maternal pulse. You usually hear it low down on the sides of the uterus.
What causes it?
It's the sound of blood rushing through the mother's dilated uterine arteries. Importantly, you can sometimes hear a similar sound over large uterine fibroids too, because they also have increased blood supply. So timing it with the mother's pulse is key.
Okay, maternal pulse, uterine souffle. What's the other sound?
The other one is the phonic souffle, sometimes called the fetal souffle. This is also a soft blowing murmur, but this one is synchronous with the fetal heart sounds.
Ah, timed with the baby's heartbeat. What causes that?
It's thought to be the sound of blood rushing through the umbilical arteries, especially if the cord is positioned just right under the stethoscope or Doppler. So, FHS fast and regular, uterine souffle follows maternal pulse, phonic souffle follows fetal pulse. Distinguishing them is vital.
Got it. What about internal examination in the second trimester? Can we still do ballottement?
Yes, internal ballottement is typically elicited between the 16th and 28th weeks.
How is that done?
During a vaginal exam, you give a gentle upward tap on the cervix or the presenting part through the vaginal fornix. Like external ballotment, you'll feel the fetus float upwards and then gently tap back down onto your examining fingers.
Why only between 16 and 28 weeks?
Before 16 weeks, the fetus is generally too small to be easily felt or displaced this way. After 28 weeks, the fetus is usually larger, fills the uterus more, and there's relatively less fluid, so it's less likely to be freely ballotable. It confirms a mobile mass within the uterus during that mid-trimester period.
Okay. Now let's move into the home stretch. The last trimester, weeks 29 through 40. What are the main symptoms now?
The symptoms shift again, becoming primarily mechanical. The sheer size of the progressively enlarging abdomen causes discomfort. Things like dyspnea, shortness of breath, especially when lying down or exerting oneself, and palpitations become more common.
And there's a key event called lightning, usually around 38 weeks.
Yes, lightning. This happens mainly in prima gravidae, first-time mothers. It refers to the sensation of relief from upper abdominal pressure.
Why does that happen?
It happens because the presenting part, usually the baby's head, engages, meaning it descends down into the pelvic brim. This lowers the overall height of the fundus, taking pressure off the diaphragm and stomach.
So breathing might feel easier.
It often does, but there's a trade-off. Because the head is now lower and pressing on the bladder again.
Ah, the frequency of urination comes back.
Exactly. The urinary frequency that disappeared after the first trimester often reappears due to this late-stage pressure.
Interesting how sundal height changes right at the end. It actually seems to go down.
It does, and that can be confusing if you don't know why. The fundus reaches its highest point, right up near the unciform cartilage, tip at the breastbone, around the 36th week.
Okay, highest at 36 weeks.
Then, especially if lightning occurs, by the 40th week term, the fundal height might actually drop back down to the level it was at around 32 weeks.
So if a clinician measures the fundus and it's at the 32-week level, how do they know if it's actually 32 weeks or if it's 40 weeks with engagement?
By checking the presenting part. You palpate the lower abdomen. If the fundus is at that 32-week level, but the fetal head is still floating high, easily movable above the pelvic brim, it's likely a 32-week gestation.
Okay.
But if the fundus is at that same level, yet the head is engaged, meaning it's fixed and dipped down into the pelvis and not easily movable, that indicates it's a term pregnancy, likely 40 weeks. The engagement status is the key differentiator.
That makes sense. To make fundal height assessment more objective, we use the tape measure, right? The symphysis fundal height, or SFH.
Correct. SFH measurement is standard practice. You measure in centimeters from the upper edge of the symphysis pubis over the curve of the abdomen to the very top of the uterine fundus.
And how does that relate to weeks?
The general rule of thumb after about 24 weeks and up until around 36 weeks is that the SFH in centimeters roughly corresponds to the number of weeks of gestation. So at 30 weeks, you'd expect the SFH to be around 30 centimeters.
Is there an acceptable range of variation?
Yes, a variation of plus or minus 2 centimeters from the expected width is generally considered within the normal range. So at 30 weeks, anywhere from 28 to 32 centimeters might be okay.
But if it's outside that range, like significantly smaller or larger?
That would be a red flag. Significantly smaller might suggest intrauterine growth restriction, IUGR, inaccurate dates, or low fluid. Significantly larger could mean twins, macrosomia, a large baby, polyhydramnios, too much fluid, or, again, inaccurate dates. It definitely warrants further investigation, usually with ultrasound.
And by this late stage, fetal parts the baby's lie, presentation, position, all that is much easier to determine by palpation, right?
Much easier. Braxton Hicks contractions might also be more noticeable to the woman and certainly palpable by the examiner. Fetal movements are usually very pronounced. It's all becoming much more obvious.
Okay, let's transition to Section 4, imaging, differentiation, and prior experience. And the undisputed king of imaging in pregnancy is sonography or ultrasound.
Absolutely. Ultrasound is the gold standard. It provides confirmation, incredibly accurate dating early on, assessment of fetal well-being, anatomy checks. It's indispensable.
Let's break it down by trimester. What can ultrasound show us in the first trimester?
Very early on, using transvaginal ultrasound, we can see an intradecidual gestational sac, GS. This might be visible as early as 29 to 35 days from the LMP, so around 4.5 weeks.
That early. Wow.
Yes. Then the yolk sac, which is a crucial early structure, usually appears within the sac around 5.5 menstrual weeks. By 6 weeks, you can typically visualize the fetal pole, the first visible sign of the embryo itself, and crucially, see or detect cardiac activity, the heartbeat.
And for dating in this early period, what's the best measurement?
The crown rump length, or CRL. That's the measurement from the top of the fetal head to the bottom of the torso. Between about 7 and 12 weeks, the CRL is the most accurate predictor of gestational age we have.
Oh, accurate.
The variation is typically only plus or minus about 5 days. That's because early embryonic growth is very consistent across pregnancies before individual genetic and environmental factors start playing a bigger role.
So CRL is king for early dating. Is there anything ultrasound needs to differentiate from a true pregnancy sac?
Yes, critically, especially if there's pain or bleeding, ultrasound helps differentiate a true intrauterine gestational sac from a pseudogestational sac.
What's a pseudogestational sac?
It's a collection of fluid or blood within the uterine cavity that can sometimes look like an early gestational sac on ultrasound, but it's actually associated with an ectopic pregnancy, a pregnancy growing outside the uterus, usually in the fallopian tube. Distinguishing these is vital.
Okay. Moving to the second trimester ultrasound, usually done around 18 to 20 weeks. What's the focus then?
The focus shifts. While dating is still refined, the main goal of the mid-trimester scan is a detailed survey of the fetal anatomy, checking all the organs and structures for normal development. We also assess placental location and amniotic fluid volume.
How accurate is dating in the second trimester?
It's still very good, generally considered accurate to within plus or minus 8 days, especially between 12 and 20 weeks. We use fetal biometry for this.
Biometry meaning measurements. What specific measurement?
The standard ones are the biparietal diameter, BPD, and head circumference, HEC, measuring the head, then the abdominal circumference, AC, measuring the tummy, and the femur length, FL, measuring the thigh bone. These 4 measurements are plugged into formulas to estimate gestational age.
You mentioned BPD. Is there a specific way that has to be measured for consistency?
Yes, the standard technique for BPD is crucial for accuracy. It's measured at a specific cross-section of the fetal head that shows certain landmarks like the thalami and cavum septum pellucidum. The measurement itself goes from the outer edge of the skull bone closest to the transducer to the inner edge of the skull bone farthest away. Leading edge to leading edge.
Outer to inner. Got it. Consistency is key. Now, in the third trimester, what happens to dating accuracy?
It declines significantly. By the third trimester, the potential variation in estimated gestational age based on biometry can be plus or minus 3 Rits or even more. Individual growth patterns diverge too much.
So the focus shifts away from dating.
Entirely. The third trimester scans are primarily focused on assessing fetal growth, looking for signs of IUGR or macrosomia being too large. The abdominal circumference, AC, becomes particularly important here as an indicator of growth and well-being. We also reassess amniotic fluid volume, often using the amniotic fluid index, or AFI.
AFI, how's that measured?
The uterus is divided into 4 quadrants, and the deepest vertical pocket of fluid free of fetal parts or umbilical cord is measured in each quadrant. The sum of these 4 measurements in centimeters is the AFI.
And what are the significant thresholds?
Generally, an AFI less than 5 centimeters is considered oligohydramnios, too little fluid, which can be concerning. An AFI greater than 25 centimeters is considered polyhydramnios, too much fluid, which also needs investigation. We also check placental location, thickness, and look for any abnormalities.
Are there other imaging techniques used besides ultrasound?
Occasionally. Magnetic resonance imaging, or MRI, might be used in complex cases for very detailed fetal anatomy assessment, especially looking at the brain or complex malformations where ultrasound is limited. Historically, X-ray could show the fetal skeleton from about 16 weeks, but due to radiation concerns, it's virtually never used for pregnancy diagnosis anymore.
Okay, let's switch gears slightly and talk about parity, the signs of previous childbirth. How can a clinician often tell if a woman has given birth before Paris versus never having given birth, nulliparous?
There are several physical changes that often persist long after childbirth. In a Paris woman, the breasts might be less firm, more flabby, and the nipples might remain more prominent, especially if she breastfed. Pigmentation changes, like the secondary areola, might persist.
What about the abdomen?
The abdominal wall is often laxer after stretching. You might see persistent silvery white striae, stretch marks, and the linea alba, the midline tendinous ref, might be wider. This abdominal wall laxity can also make the pregnant uterus feel broader and rounder on palpation compared to the firmer feel in a nulliparous woman.
And down below, perineum and vagina.
The perineum might show scarring from tears or an episiotomy. The vaginal opening, the introitus, might appear more open or gaping, and you might see remnants of the hymen called carunculae myrtiforms. The vagina itself often feels more spacious or roomy.
But the most definitive sign is often the cervix, isn't it?
Yes, the cervix usually tells a very clear story. In a nulliparous woman, the cervix is typically conical or cone-shaped, and the external os, the opening you see, is small, round, like a dimple or pinpoint.
Okay, conical with a round os. How does it change after childbirth?
In a Paris woman, the cervix often becomes more cylindrical in shape. Crucially, the external os, having been stretched dramatically during birth, heals differently. It typically heals as a transverse slit, sometimes quite wide, often described as fish mouth-shaped or patulous, meaning it might even admit the tip of a finger easily. That change from a round os to a transverse slit is a classic, often permanent, sign of parity.
A very clear anatomical difference. Okay, finally in this section, let's tackle the differential diagnosis of pregnancy. What conditions can mimic pregnancy or get confused with it?
This is where careful assessment is crucial. The most fascinating, perhaps, is pseudocyesis.
Phantom pregnancy or spurious pregnancy?
Exactly. It's a psychological condition where the woman has a profound, unshakable belief that she is pregnant, despite not being so. And remarkably, her body can sometimes produce symptoms that strongly mimic pregnancy.
What kind of symptoms can occur in pseudocyesis?
It can be quite convincing. Cessation of menstruation, amenorrhea, can happen due to psychological stress affecting hormones. Abdominal enlargement is common, often due to intestinal gas, fat deposition, or postural changes. Some women even experience breast changes or secretions. And they might perceive fetal movements, which are usually just strong intestinal peristalsis or abdominal muscle contractions.
So how do you make the diagnosis?
You have to rely on the objective, absolute signs. In pseudocyesis, there will be no fetal heart sounds, no fetal parts palpable. The immunological pregnancy test will be negative, and crucially, an ultrasound will show an empty uterus. It requires sensitive handling, as the woman's belief is very real to her.
What about actual physical swellings that could be mistaken for a pregnant uterus?
There are a few main contenders. First, a large cystic ovarian tumor.
How would that differ?
Growth is usually much slower, over many months or even years. Amenorrhea is typically absent unless the tumor is hormonally active. On palpation, it feels distinctly cystic, like a fluid-filled balloon, rather than the firmer, fleshy feel of a uterus. And importantly, you won't feel Braxton Hicks contractions. Ultrasound confirms it's separate from the uterus.
Okay, what else?
A large uterine fibroid, myoma. Again, growth is usually very slow over years. Amenorrhea is uncommon. Fibroids often cause heavy periods. They feel firm or even hard, often irregular in shape. And again, no Braxton Hicks, no fetal heart, empty cavity on ultrasound, though the fibroid itself is visible.
Any infectious causes?
Yes, encystic tubercular peritonitis is a possibility, especially in areas where TB is prevalent. There might be a history of tuberculosis. Amenorrhea could be present due to chronic illness. The swelling might feel more ill-defined, doughy, perhaps. The key on examination, especially pelvic exam and ultrasound, is identifying a normal-sized uterus that is separate from the main mass of encysted fluid or inflammation.
And one simple thing that can sometimes be mistaken, especially if there's urinary retention.
Ah, yes, the classic trap, the distended urinary bladder. This can happen, for instance, if a retroverted, tilted backward, early pregnant uterus traps the urethra, causing chronic retention. The full bladder can feel like a large pelvic mass.
How is that resolved?
Simply by passing a urinary catheter. If the mass disappears after emptying the bladder, the diagnosis is made. Always consider catheterization if there's any doubt about a large, smooth pelvic swelling.
Good point. Okay, this leads us logically into our final section, Section 5. Precision and prediction gestational age and fetal weight. Getting the dates right is just so critical, isn't it?
It's everything, especially for managing high-risk pregnancies, timing interventions, monitoring growth. Accurate dating is the foundation.
What's the most reliable starting point?
An accurate last normal menstrual period, the LMP. If the woman is certain about the first day of her last normal period and her cycles are regular, that's usually the best anchor point.
But how often is the LMP unreliable?
Studies suggest maybe 20 to 30% of patients either forget the date, are unsure, or have factors that make the LMP unreliable. For example, if conception occurred during lactation amenorrhea while breastfeeding before periods returned, or right after stopping birth control pills, or if there was bleeding in early pregnancy that was mistaken for a period.
So when the LMP is considered reliable, what's the standard way to calculate the due date?
We use Nagel's formula.
How does that work?
You take the first day of the LMP, add 7 days, and then subtract 3 months, or add 9 calendar months. That gives you the estimated date of delivery, EDD.
But there's a catch, right? It assumes a perfect cycle length.
Exactly. Nagel's formula assumes a standard 28-day menstrual cycle with ovulation occurring on day 14. If a woman's cycles are consistently longer than 28 days, say 35 days, ovulation happens later. So you need to add the difference, in this case 7 days, to the EDD calculated by Nagel's rule.
And if her cycles are shorter, say 24 days?
Then ovulation happens earlier. So you need to subtract the difference, in this case 4 days, from the calculated EDD. This correction for cycle length is really important for accuracy, but sometimes gets overlooked.
Okay, what about other clinical milestones? Can quickening still be used?
As we mentioned, you can estimate by adding 22 weeks for prima gravidae or 24 weeks for multipari to the date the woman first felt quickening. It's less precise than LMP or ultrasound, though.
What if the date of conception is known for sure?
If the exact date of fruitful coitus is known, you can add 266 days, which is the average fertilization age, to that date to get the EDD. This is potentially very accurate, but only works if conception resulted from a single known instance of intercourse. Even then, there's biological variability, maybe 50% accuracy within 7 days, either side.
Since clinical dates can be uncertain, how do investigation results help establish the EDD?
They are often more reliable, especially early ultrasound. You can also estimate EDD based on when other milestones were confirmed. For example, adding roughly 36 weeks from the date in the first positive sensitive pregnancy test, since that usually occurs around 4 weeks gestation, or adding about 30 weeks from the date fetal heart tones were first documented by Doppler, usually around 10 weeks gestation.
So how do clinicians reconcile potentially conflicting dates from LMP and ultrasound?
There's a standard clinical practice. You compare the EDD calculated from the LMP with the gestational age estimated by an early ultrasound, ideally first trimester CRL or second trimester biometry before 20 weeks. If the difference between the two dates is less than 10 days, you generally stick with the EDD based on the LMP.
Okay, less than 10 days, keep the LMP date.
But if the discrepancy is greater than 10 days, the clinical practice is usually to revise the EDD based on the ultrasonographic findings, because those early measurements are considered more biologically accurate than potentially uncertain menstrual recall.
Right. The ultrasound becomes the definitive data if the discrepancy is large. Okay, finally, let's talk about estimating fetal weight, or EFW. Why is this so important, especially later in pregnancy?
Estimating fetal weight is critical before making decisions about induction of labor, elective cesarean sections, or managing suspected growth problems like IUGR or macrosomia. Knowing the approximate size helps anticipate potential delivery complications.
Is there a peak time for fetal growth?
Yes, the maximum growth velocity, the fastest rate of weight gain, typically occurs between 32 and 36 weeks, averaging around 26.9 grams per day. It slows slightly after that, maybe to 24 grams per day between 36 and 40 weeks. Assessing weight during that peak growth phase is important.
Is there a way to estimate weight clinically, just using hands and a tape measure?
There is a clinical formula, Johnson's formula, which uses the symphysis fundal height, SFH measurement.
How does Johnson's formula work?
It uses the SFH measured in centimeters. The basic formula is EFW in grams equals SFH in centimeter minus a correction factor times 155.
What's the correction factor? Depends on engagement, right?
Exactly. You need to assess how low the fetal head vertex is in the pelvis. If the vertex is still high, at or above the level of the mother's ischial spines, a bony landmark in the pelvis, you subtract 12 from the SFH before multiplying by 155.
Okay, SFH minus 12 if head is high.
But if the vertex has descended and is below the level of the ischial spines, meaning it's engaged, you only subtract 11 from the SFH before multiplying by 155.
So SFH minus 11 if head is low engaged. Why the difference?
Subtracting a smaller number, 11 versus 12, when the head is engaged, accounts for the portion of the baby's weight that's already down in the pelvis and not contributing to the abdominal fundal height measurement. It's a way to clinically adjust for engagement.
Clever. How accurate are clinical formulas like Johnson's?
They provide a rough estimate, but they can be significantly affected by factors like maternal obesity, amniotic fluid volume, and examiner variability. They're useful for a quick bedside guess, but not very precise.
So for more reliable estimates, we turn back to ultrasound.
Absolutely. Sonographic formulas are much more objective and generally more reliable, typically estimating the weight to within about 10% of the actual birth weight.
How do the ultrasound formulas work?
They are complex regression equations built into the ultrasound machine's software. They take the biometric measurements we discussed, BPD, HC, AC, FL, and combine them using specific validated mathematical models. Famous ones include Shepard's formula, which primarily uses BPD and AC, and Hadlock's formulas, which often incorporate all four measurements.
We don't need the exact Hadlog formula, I imagine, but what's the underlying principle? Why combine all those measurements?
Different measurements reflect different aspects of growth. Head measurements, BPD-HC, reflect skeletal growth and brain size. Femur length, FL, reflects linear skeletal growth. But the abdominal circumference, AC, is particularly crucial for estimating weight.
Why is AC so important for weight?
Because the AC reflects the size of the fetal liver, which stores glycogen, and the amount of subcutaneous fat around the abdomen. It's essentially a proxy for fetal soft tissue mass and nutritional status.
So AC tells you about how well fed the baby is.
In a way, yes. That's why in cases of intrauterine growth restriction, IUGR, the AC is often disproportionately smaller than the head circumference. The fetus might be sparing blood flow to the brain at the expense of growth in the liver and abdomen. So AC is a very sensitive indicator of growth problems and heavily weighted in most EFW formulas.
And based on this estimated fetal weight, we can classify the baby's size relative to gestational age.
Exactly. We compare the EFW to standard growth charts for that specific gestational age. If the EFW is less than the 10th percentile for that age, the baby is classified as small for gestational age, SGA. If it's greater than the 90th percentile, it's classified as large for gestational age, LGA. These classifications immediately guide further management and surveillance.
This has been incredibly thorough. We've really traced the diagnostic journey from those very first, often vague, presumptive symptoms like a missed period or morning sickness.
Through the more objective, probable clinical signs discovered on examination, things like Goodell's softening cervix, Chadwick's bluish hue, the unique feel of Hegar's sign.
Right up to the absolute undeniable signs. Actually hearing the fetal heart, the examiner feeling those distinct fetal movements, and of course the definitive evidence provided by ultrasound imaging.
And we constantly kept in mind that critical distinction between the clinician's 280-day gestational age calculated from the LMP and the embryologist's 266-day fertilization age, reflecting true time since conception.
We also navigated the science of confirmation, the different immunological tests, from simple agglutination methods to the high-precision quantitative assays like RIA and ELISA, understanding how they detect HCG and their specific uses, like monitoring ectopics or molar pregnancies.
Understanding the principles behind the tests is just as important as knowing the clinical signs.
Absolutely. Now, here's a final thought to leave you with, something really provocative that arises from this deep dive. We've seen how incredibly fast and sensitive modern diagnostics have become. Tests like IRMA and the best ELISAs can confirm pregnancy biochemically before any physical signs are apparent, sometimes even before a missed period.
That really does push the start line for medical awareness and potentially medical care significantly earlier than ever before.
So here's the question. Knowing that fertilization, the true biological start, happened 266 days before term, and having the ability to pinpoint this very early with high certainty using beta-HCG levels and early CRL measurements from ultrasound, which, as we discussed, can be more accurate than LMP. How does this level of early biophysical certainty change clinical decision-making?
That's a deep question.
Think specifically about situations where the LMP date might be off by several weeks. How does knowing the true, biologically confirmed gestational age impact decisions, where timing is absolutely critical, like deciding exactly when to give antenatal corticosteroids to mature fetal lungs if preterm birth is anticipated? Getting that timing wrong by even a week or two, based on an inaccurate LMP could reduce the benefit, right?
That's precisely the point. The narrow window for maximum benefit from interventions like steroids makes that early, accurate, biologically based dating incredibly powerful. Relying solely on a potentially flawed LMP when we have tools offering greater precision weeks earlier. It fundamentally changes the risk-benefit calculation for intervention timing.
It shifts the foundation from estimation towards biological certainty right at the start, something crucial to consider in practice. Thank you for joining us for this deep dive. We hope you feel truly equipped now to master the science and the subtleties of pregnancy diagnosis.